Okay, yeah. Good evening, doctors, speakers, and colleagues. Welcome to Envista Imaging webinar, Integrating Cbct into Your Dental Practices, Visualize Your Treatment from Endo to Maxillofacial Surgery. This very moment was held by cooperation between Envista Imaging Indonesia, Thailand, and Vietnam, our channel partner PT Andini Sarana, and Indonesia Dental Association branch East of Jakarta. My name is Elizabeth. I'm Clinical Manager for Envista Indonesia, and I will be your host for today. It's been a great honor for us to be here and welcome each and every one of you in this webinar. And before we continue, let's together we take a respectful position to sing Indonesia National Anthem, Indonesia Raya, and continue with March of Indonesia Dental Association.
Siap selalu
Okay, thank you so much. Now, please allow me to read webinar rules and post-test. And kindly note that post-test is required only for Indonesian participants. Please log in using your registered name and kindly use Q&A feature or raise hand if you have any questions. For the post-test, link can be accessed only one time. Link is accessible after the webinar at 9 p.m. Jakarta until 3 p.m. on October 21st. Please use the same email as registered for this webinar. Minimum score is 70% to get the credit, and certificate will send within 1 month after webinar. And if you need any assistance, please kindly contact Mas Ade. The number is on your screen. As an additional announcement, this webinar also available in Vietnamese language. So for the Vietnamese doctors, you can choose Vietnamese language by clicking interpretation button, this one, and then you can choose Vietnamese, and then you will hear the interpretation Vietnamese language. And this is our agenda for today. Without further ado, I would like to welcome Dr. Gaga Daru, the chairman of Indonesia Dental Association, branch of East Jakarta, to give welcome and opening speech. Welcome, Dr. Gaga. Good evening.
Good evening.
Okay, please kindly take your time.
Thank you, Mrs. Yosote. Good evening, thank you, Dr. Bipon. Dr. Nusahanana from Thailand, Dr. Istirahayu from Asia, and Dr. Mandai Kong from Vietnam, the speaker in the G-Countries webinars. Sorry, I used to chat in my meeting. Okay? Assalamualaikum warahmatullahi wabarakatuh. Selamat malam, salam sejahtera bagi kita semua. Terima kasih sebelumnya kami ucapkan kepada para narasumber dari Thailand, Indonesia maupun Vietnam, serta dari Kapo yang telah memfasilitasi kegiatan webinar 3 negara kali ini. Memang dari kegiatan ini kita bersama untuk masyarakat webinar untuk menambah wawasan secara dokter gigi baik di Indonesia maupun di 3 negara lainnya untuk mengikuti perkembangan zaman yang ada sekarang. Apalagi di masa sekarang ilmu kedokteran teknologi gigi selalu berkembang dari masa ke masa. Untuk itu kepada dokter gigi yang mengikuti kegiatan webinar, mudah-mudahan ada masukan, kita bisa sharing, kita bisa bertukar pikiran dengan dokter-dokter yang dari 3 negara, sehingga kita bisa membandingkan bagaimana perkembangan ilmu kedokteran gigi baik di Indonesia maupun di negara Asia lainnya. Saya ucapkan terima kasih juga kepada seluruh sponsor dan juga kepada panitia yang telah menyelenggarakan kegiatan webinar ini, dan juga para peserta yang telah bergabung dalam kegiatan ini. Mudah-mudahan kegiatan webinar ini dapat menambah wawasan kita semua. Mungkin itu saja dua dari kami. Kurang lebihnya kami mohon maaf. Kami kembali lagi ke Dr. Isabel. Sekian, assalamualaikum warahmatullahi wabarakatuh dan selamat malam. Thank you.
Baik. Terima kasih banyak Dr. Gaga. What a meaningful and important notes for all of us. Thank you so much once again, Dr. Gaga. Okay, now I would like to introduce our moderator today, Ms. Tiffany Wang. Ms. Tiffany Wang is APEC Associate Product Marketing Manager for Imaging Portfolio at Envista. She is an experienced clinical trainer with a demonstrated history of working in medical radiology department and dental device history. Skills in X-ray, ultrasound, CT, Cbct, diagnosis radiography, dentistry, and dental imaging. Strong information technology professional with a Bachelor of Science focused in biological and biomedical science from National Yang Ming University, Taiwan. Okay, welcome Tiffany. Are you there?
Thank you, Liz. Hi, I'm Tiffany. I hope everyone has a great evening. So today I will be introducing our doctors for you, and hopefully everyone will enjoy this small clip that we prepare. We have 3 speakers today, each from Indonesia, Thailand, and Vietnam. So let's take a look.
Oke, 280 semakin.
Okay, so first of all, please allow me to welcome Dr. Iti from Indonesia. Her topic today will be dental 2D and 3D radiography quality discussion and introduction to large FOV CBCT technology and its application. Welcome, Dr. Iti.
Well, thank you. Thank you, Tiffany. Thank you, moderator. Okay, I would like to share my screen. Okay, is it good, Tiffany? Yeah.
Yes, perfect.
Okay. All right. Yeah. Thank you, moderator, and good evening, everyone. Selamat malam. First, I would like to say my greatest appreciation to Indonesian Dental Association, the branch of East Jakarta, and of course to Envista, CAFO, Imaging, and also Andini for having me so I can be here and join on this interesting event. And of course, not to forget to mention, I would like to send my gratitude to all audiences across Asia. The other side of this pandemic is now that I can be here in the same platform with all of you and also with the expert from Thailand, Dr. Cbct, and also from Vietnam, Dr. Pon. All right. My name is Isti Rahayu Suryani. I am a lecturer in University of Gadjah Mada in Yogyakarta, Indonesia, and also I am an oral radiologist in Gadjah Mada University Dental Hospital. But now I have a chance to pursue my PhD degree in Leuven, Belgium. This is a glimpse of the city that I live now in Leuven. Leuven is a student city that only 20 minutes by car or by train from Brussels. So I study in Catholic University of Leuven, which is the oldest university in Belgium. In this picture, you can see, you can see this one. This is the Stadhuis or City Hall of Leuven with the Grote Markt in the beside, with many cafes and also with the famous Belgian waffle and also free tour. It's familiar if you know it's French fries, although it's actually came from Belgium. Okay, for this session, I would like to divide my presentation into two topics. First, about the quality assurance in 2D and also 3D radiography. And the second one is the introduction to large FOV on CBCT technology. Before we jump to the next slide, I would like to talk about the definition of quality assurance or quality control in radiology. or in dental radiology in specific, QA or QC in radiology is the series of procedure to ensure optimal and consistent operation of each component in the imaging chain. We know that imaging chain cannot be separate each other. It's about dental office, it's about radiologic facility, radiologic staff, and also the patients. So to assure the quality radiographs and maximum diagnosis, and while minimum exposure to the patients and personnel. This principle, it's simply like the economic principle that we know, that we can spend minimum money to get a valuable things or a lot of things. So it's also in radiology, we have the principle, it's called ALARA. The meaning is as low as reasonable achievable. We can use minimum radiation to get high quality image and decrease retakes. In the QA in radiology, I divided into two groups. We cannot remove the conventional one. The conventional is the analog processing or the film processing, and the second one is the digital processing. In conventional, we have to make sure about maintaining the processing control, the performance of X-ray input, the performance of the view box or illumination box, the performance of the cassettes and dark room. In digital processing, we know that we have to maintain the image receptor. Image receptor here is also divided into two groups. The one is the CCD. CCD is the direct digital radiograph, which called charge or charge coupled device. The second one is post-pore plates, or I will say the post-pore plate later in PSP. And also we have to always make sure that the digital monitor that we use is always in the good monitor, in the good condition. The last one is the software that dedicated in the equipment. This software usually is the bundle with the equipment itself. So for the radiograph exposure and technique, we have to do some tasks. That this task usually that have to do in the daily task, weekly task, or the monthly task. For the daily task, we have to find, we have to make like a log or list to make sure that all error for images that must be re-exposed are always recorded. And the weekly task, we have to review why we have to retake this one. Why to identify, and we can identify any recurring problems with the film processing condition or the operator technique, and maybe there is something wrong with the staff education. So during the weekly task, we can have to make advance to make a better radiograph exposure. To the monthly task, we have to check exposure charts. We can see here, this is the sample of the exposure charts. There's some lists of the incisors, maybe at the first exposure time is around 25 seconds, 0.25 seconds premolars, and the adults, edentulous, like this. And it should be the exposed is always be in the good exposure time. So it's always the same with the list. So we have to always also check the protective aprons and collar, and always visually for evidence if there is a crack in the collar or in the aprons, because if there is a crack, it will be not good also for the patients, also for the operators. For the real yearly tasks, we have to see that if there is a leakage in radiation, and collimation and the beam alignment, the collimator that we use for the periapical, for example, it should be no greater than 2.75 inches or around 7 centimeters. And the tip should be closely aligned with the X-ray beam. The beam energy, we can always measure about the KVP, the MA, the timer, and we always take a look about the tube head stability. The tube head should be stable when placed around the patient's head. So, for example, if there is like a damage, sometimes we make the tube in front, like in the front of the patients, but then if there is a damage, the tip is always going down. If we see something like that, we have to call for the manufacturer to repair of this damage. And about the last one is about focal spot size. If an enlarged focal spot size will be contributes to geometric fuzziness, and also about the noise will be increase and make effect to the resultant image. I'm not going to discuss about film-based radiology because I think it's barely used now in this modern area. Usually all the installation, radiographic installation using digital. So I just want to point that the most common cause of poor film radiograph processing is caused in the darkroom. So the faulty because of the fault in the processing of the developer solution, of the fixer solution, and so on. And in the film base, we have to always control that call about sharpness and resolution. The sharpness here is the ability of the radiograph to precisely define an edge. Something like that. We can see the DEG, dental enamel junction. We can see which one is amyl, which one it's called dentin, and which one called pulp. So the resolution is the ability of the radiograph to record separate structures that are close together. Something like that. This is the full mouth series that we can see each teeth we can see the separate structure. And the next one in the film radiograph, we always to check the processing solution, and we always clean the processing equipment and so on. Okay, for the digital image, we have we are not going to do the daily tasks and also weekly tasks, and the one that we have to do always is the monthly task. We have to make sure that we have to do the calibration on the image display, in the monitor display, and also when the radiograph that produced is always the same. So we have to, it should be checked in monthly basis. And also we have to do the test pattern image. And the next one, we have to make sure to inspect the image receptor. The image receptor for the photosimulable phosphor plates. This one is the PSP plates that is almost the same like analog film that have a thin image, and also it's flexible. If there is a scratch, it should be removed. And the next one is the inspect to CCD or CMOS sensors. The CMOS sensors here is having cable connections that always have a good connection with the computer. So USB here is always intact. This one, the CCD and CMOS receptor is like not sometimes patient is not comfortable in this image receptor. So usually many dental installation using the PSP phosphor plates. I would like to show you the common faults in dental radiograph. This is a film radiograph that have light radiograph. You can see it's very light here. It's because because of the processing errors and because of the underexposure. For the processing errors, because of the underdevelopment about the developer that already contaminated or diluted, and also the excessive fixations. And under exposure, we can have this like radiograph because in insufficient MA, insufficient KVP, and it's almost because of the insufficient exposure time. And also film source distance is too long. And maybe sometimes if we put the film inside the mouth but it's reverse, it can be also become a radiograph in light condition. The dark radiograph, something like that, is the opposite of the light radiograph. It's too dark here. It's also caused by two errors, is because the processing and also the overexposure. The dark radiograph is the opposite exposure of the exposure error of the light radiograph. Another common fault in periapical radiograph is insufficient contrast. You can see we cannot see clearly the DEG here, and almost the same with we cannot see which one is dentin, which one is enamel, because of the underdeveloped, underexposure, or excessive KVP, excessive film lock. We can have also film fog. There is a fog like a noise here. And this one is because of the improper light. I would like to say that in periapical radiograph, in the processing area, we can still have like red light to on. So maybe because it's too dark, or maybe it's too bright, it become make the film make the fog on the film. Still in film-based radiograph, you can see this one. There is a dark spot or lines here. It's because of fingerprint also, and maybe because of the protective wrapping paper and film in contact with tank. Usually is we not careful enough, so there is like a black hole or a black line here. And also it can be happen because of the film contaminated with developer, and it could be also because of the excessive bending. This one, the light spot, it's the opposite, the other side of the dark spot. The film contaminated with fixer before processing, and also film in contact with tang or another film during development. Still, yellow brain stains is also common fault that usually we face in the installation. This one, the partial image, because of the cone cutting, it's error in the processing. No, I mean in the exposure. There is a blurring also. Blurring is almost the same image like the fog film. It's because the movement of the patient and also movement of the film itself. Film not stabilized. Usually in the when we expose on children or expose on the patient with edentulous, because patient with edentulous have lots of saliva, so to make a film stable is a bit difficult. In digital radiography, you can see that this is the upside is the charge coupled device or CCD, the direct digital radiograph, and the down part is the PSP. In the CCD or in the PSP, usually in the CCD there are a lot of noise because it's not flexible enough. So for me, I think for oral radiologists is much better to see in PSP here. And this one is the noisy image that caused in the digital radiography, usually in CCD. But because on digital radiography, we can make like image processing here, the noisy image can be removed, so we can have a better image here. non-uniform image density because of the two image receptor came stuck together, and it will be make like a dark line here. This one distorted image, the A, the moderate bending. So when it retake image with the moderate bending, it's always still okay now. And this one, the C, it's the severe bending. And after retake, the severe bending is already normal. This one, the fault then unacceptable by the radiologist. If you see the radiopaque line here in the root canal, the radiologist will interpret this one as root canal treatment. But actually, when see further here, the radiopaque lines, it's going through to the crown and almost to the edge of the image receptor. In this case, the image receptor must be replaced, and actually, after it's been replaced, the white radiopaque here is gone, and there is no root canal treatment here. This is because the scratch in postpore surface. This one is because the exposure of the pellet to the liquid disinfectant is because the second damage caused by the disinfectant that still remain or not totally clean from the receptor. It will also make bias on the interpretation. This one, the trace of the disinfectant. Okay, for the jump to the discussion about panoramic, I would like to show you our previous study that in 2018, it's about the dedicated software for image processing work. We do scoring here on 200 dental panoramics. Then we measure the definition of some points that shown in panoramic radiograph. At first, the anatomical structure were scored range from 1 to 5. The 1 if not visible, and 5 if clearly visible. Like for example, in the dental enamel junction, if in the dental enamel junction in the each region is clearly visible, we put 5 on the list. And also in the periodontal space and lamina dura, shape of the roots, shape of the crowns, definition of the alveolar crest in the alveolar bone, and the definition of trabecular pattern in the alveolar bone. This can be, if you have like panoramic radiograph, this scoring chart can be used to score this image quality is good or not. And the results of my study here, you can see in the anterior part here, you can see that the apical part of the anatomical in the teeth 31, 32, 41, 42 is not clearly enough. But then after processing, this is the highlight. And after processing, we can see that this, after processing that we can see the apical, we can see the lamina dura, we can see the periodontal space here clearly shown on this radiograph. So in the conclusion on my study that the dedicated software only work in the anterior side of the panoramic. So another common fault in the panoramic radiograph is that chin is too high. And then sometimes patients doing like this, and it will make the radiograph appear flat or inverted. And this one, the opposite, the patient is too downward, so the occlusal and the chin is become the U shape or V shape. So sometimes it will be severe downward, will be cutting on the superficial region of the radiograph and make distortion of the anterior teeth like this. It's become too small or too short. This one also improper neck position with the large radiograph region in the middle because of the patient has neck angled forward. So it will be superimposition with the vertical bone of the head. Another common fault in panoramic radiograph that here you can see the radiolucent image of the anterior and not just anterior, but also in the posterior. But that will be disturbing when you interpret the apical side of this area. It's because of the dorsum of the tongue was not positioned flat against the hard palate. So it's resulting the airspace below the hard palate, so facilitating the apical of the maxillary teeth. This one is the common fault in panoramic radiograph. So the next one, the outline of the second ones is I will discuss about combined computed tomography. I will show you before we talking about the CBCT, but I will explain to understand CBCT in simple way. I would like to give one of opinion about life before. In my opinion, from every aspect in life must be seen not just from one perspective, but in B2 or 3 perspective. For example, in this picture, this charming prince came out from the car and focused on his finger right here. And you will think, oh God, what is he doing? And then in the next picture, another reported upload the same picture, but with different angle. You will see that he just made the 3 fingers actually, not 1 finger. But you think if he is doing like this, this one, why radiologists want to view. At the lateral view, you see that the finger of the prince is only 1, you know, the meaning of this finger. And then in the anterior posterior view, we know that actually he has 3 fingers. And also the second example, this is the picture during Obama's speech. If you see the man with the blue t-shirt here, you see that he has a short hair, but then there is another picture. You see that from another angle, you see that actually there is a beautiful woman behind this person. So in clinical relevance, so I would like to show you, this is a crop panoramic and focus on this 44, tooth 44. There is a small here diffuse radiolucent on the apical of the 44. But then in the coronal view in CBCT, this is a panoramic, only crop panoramic with 2D. This is a 3D image. You see that the radiolucent lesion actually is the almost destruct the cortical border of the buccal side. And it's quite big, it's around 1 centimeter, I think. So this is how we understand CBCT. It's CBCT from 2D, we can see only from the buccal side or from the labial side, but from CBCT we can see from another different angle. We have like sagittal view, coronal view, and also axial view. Before continue to explain about CBCT, I want to explain how the capture of the CBCT on a video. Oh, why? I'm sorry, I think it's Okay, I don't know why it's not work here. Okay, at this point, I don't know what happened error in my video, but I just want to show you that before we do the CBCT, we have to make sure that which region that we want to expose. For example,
Sorry, Dr. Isti, sometimes
yeah,
just need to click it one more time to play the video.
I don't know, it's not work.
Okay.
Yeah, we have, maybe I will end the slideshow and put here. Yeah, okay. Maybe it worked like this.
Yes, thank you
Okay,
so much.
at first we have to, can you see my screen?
Very clear.
Yes. Okay. This is at the first we have to choose the option 3D, and then we choose the which region that we want to expose here. And there's option from the equipment, from the machine. And then we can press the home button here. And the machine will start to the first position. At first, we have to remove all the accessories in patients, the earrings, the glasses. We have to remove all these accessories because it will be make artifact, and it will cause the errors in the diagnostic of the radiograph. Is we remove this one, and the patient place the lid apron, and don't forget, if you use the lid apron, don't use the collar apron. Use only the body apron, because the collar apron will also make errors on the radiograph. In the chin rest configuration, you have two configuration if you want to expose on the upper jaw or if you want to expose on the lower jaw. And then put the chin rest here in the machine, and also the head positioning device. And put also disposable covers. And the patients pass to go to the machines and use two finger to raise or lower the unit. And usually the machine have like a touch screen, so you no need to worry. It's easy to use for the machine. This one, the align of the patients, you have to make sure the aligned of the patient with the positional light, usually red here. And patient move step forward, and see the FHP of the patients. It should be aligned with the FHP of the light. If not, is patient. There is also mirror in front of the patients. So the middle side, middle part of the patient, it should be aligned also. And then secure head positioning device. At first, before you continue to expose, there is an option to scout image. The scout image is the very low exposure image that use only that if you know there is an error like this, the patients need to come forward. You can move forward the machine, or the patient is a bit not too good in the positioning. You can also do without patients remove from the machines. And also the scouting image can be used that patients know first what the treatment that will be done. So the Next one, the patient swallow, place tongue, and inform patient that the machine will rotate. Sometimes there is a noise, and for the large especially, there is a large noise happen here. Okay, so you will have the image there. Okay. And to talk about the quality of the CBCT, one point that we have to consider is the FOV. Actually, what is FOV? FOV is the field of view. Field of view is the anatomical area that will be included in the data volume or the area of the patient that will be irradiated. One FOV, I mean, one machine have different size of it, FOV. This is the example of FOV that I choose from one specific equipment, CBCT equipment. This one, the division of the FOV, the purple one ideal for few teeth, and the blue one ideal for the entire dentition. The brown one ideal for the dentition and maxilla mandible with the adjacent structure. The yellow one ideal for the TMJ. The green one is the large FOV that I want to discuss later. Smaller FOV have more information, but the bigger FOV has more exposure here. This one maybe the low FOV, it will be discussed later by Dr. GJ. It with ENDO resolution, and in the upper, in the next FOV will be discussed later by Dr. Pon for the implant planning. So I would like to talk about the application of large FOV in dentistry. It's about the clinical finding and also the related study that can be done in the using of large FOV here. At first, if you have patients come with the injury after accident by car or motorbike, for example, it is better that you choose the large FOV because we can see the fracture area caused by the trauma. The trauma, it can be in maxilla, or it can be in the mandible. So you can see here there is a fracture here in the maxillofacial, but I don't know. This one is also there is a fracture in the mandible. So you can have you can see the whole images of the patient with the large FOV. From the incidental finding of the cervical spine, usually when we have large FOV, we can have the cervical spine here. This is the patient with degenerative joint diseases of the cervical spine, C-spine here, of the C-spine number 2. And there is, and also here for number 2, number 3, there is bony changes here, and you can see there is an osteophyte here. There is also erosion and discalcification and radiopath. And another incidental finding during the large FOV exposure is the ankylosing spondylitis of the cervical spine. Here, actually, there is a radiolucent space here, but then because of the ankylosis, no space here between the spine. And the ossification on the posterior ligament here, I think I made mistake for the arrows. There is ossification of the posterior longitudinal ligament here. The degenerative changes in the spine associated with inflammation, and also usually patients have pain or stiffness. So the degenerative changes will cause the patient feel like condition that cause cervical spondylotic myelopathy, and then will lead to neurologic dysfunction of the extremities like torso and also in the sphincters. Significant changes that warrant a referral to a physician to control any symptoms. If you see in your large FOV exposure, you see something like this, you can refer to the physician for the next examinations. About the incidental finding, you can find from the review from Nora here. I include this one from this journal from Nora, beam compute tomography incidental findings. There are many incidental findings that you can see from the large FOV during the large FOV. And another one, there is a misalignment. Usually, if you find that the patient that have misalignment, so the patient that can have like a scoliosis or misalignment, because at first, actually, the patient have the abnormality of the bone. It's called a scoliosis, but sometimes it's not scoliosis, but the patient have misalignment on this C and D, which is caused by patient during scan time. And I would like also to show you what we have done in our group in omfsimpact.be. This is my research group in Belgium. This is the orthognathic surgery in the treatment of genioplasty of the patients, boy 14 years old that will have a genioplasty here in the mandible with the large FOV. And then this is the treatment after 3 years. You can see this one in the mandible. There is a remove of the genial part of the mandible. In orthognathic surgery, this one paper about also review from our member in the research group that he made like image processing during the surgery of the patient. This protocol can be evaluate the occurrence of relapse after 6 months and 1 year after surgery. At this one, at the patients with this condition, and we can see the result after 1 year surgery. And this is the bone. We can see with the different colors here. And because this is a treatment planning, we can remove like with the software, some specific software, we can remove of this part, and then we can see the result of the bone from the software. Actually, this is also another orthognathic surgery of the patients. The purpose of this study was to evaluate, to validate the 3D of the assessment of orthognathic surgery, planning accuracy post-op and pre-op. In the post-operative and pre-op surgery, in this medication with the cephalometric view, and import the DICOM image, go together with pre-operative and post-operative scan, and then go to cranial-based registration. And this one was registered onto VBR with mutual information. In conclusion, the study provides a reliable, user-friendly, and time-efficient method for evaluating the planning and also follow-up accuracy and improving the standard in orthognathic surgery. This is also the part of the study that she removed the ramus and also isolating the coronoid, and then she removed the around the sigmoid notch and split the posterior behind and include the conial angle before pre-operative and post-operative. And the result is the previous image that I have shown to you. The next study in my group is the pharyngeal airway space assessment. The pharyngeal airway space assessment has been an area of interest for clinicians, allowing efficient diagnosis, treatment planning, and follow-up patients with the dentoskeletal deformities and obstructive sleep apnea, and which might influence the dimension of upper airway space. Here, actually, this is the last study that we use. We collaborate with the biomedical engineering expert to have like artificial intelligence that that can be detected how the pharyngeal airway space, the measurement of the airway space. So this study have to project to propose the investigate the performance of deep learning with the AI. This is the segmentation first, and then 3D resolution patch, AI prediction, full restoration segmentation, and then final result, we have the size of the pharyngeal space. This one. This is the last shape of the pharyngeal space here. To accurately and efficiently diagnose, plan treatment, and follow up patient with dentoskeletal deformities. This one also will improve the patient care. The green one is the red color predictive model, and the green color the axial and coronal sagittal plane with the 3D reconstruction. The last study is the 3D ocular prosthesis. We make also in the prosthodontic area. We make image acquisition with Cbct, and then segmentation, and then 3D planning, and the size of the ocular prosthesis here. All right. But we have to make a careful attention of the use of large FOV in dentistry. This is also the paper in our lab. It's issued in 2012, that the dose received being strongly related to the field of size. You can see this is the biggest dose that absorbed is in the salivary gland. He compared between some machine that have large FOV. That the dose here should always consider relative to technical, diagnostic image quality, and depending on the diagnostic requirement. Okay, thank you for your attention. Regards from Groot Begenhof. This is the UNESCO heritage that now used for residential area in Kauluvan. If you have time later, please stop by at my house. This is my house in the end of this stone road. Okay, thank you very much. Good evening and selamat malam.
Thank you so much, Dr. Iti. I think it clears a lot of common myths or some common question that we have for the large FOVs. So thank you again, Dr. Iti. Then please allow me to welcome Dr. Gigi from Thailand. And this time, Dr. Gigi will talk about CBCT together with ENDO for us. So let's welcome Dr. Gigi. Dr. Gigi, I think you're on mute.
Okay, good evening. Thank you very much. I'm Dr. Penporn or Dr. Gigi. Today, our topic is field of view for endodontics and guidance from European Society of Endodontology. This is our main paper today. Yeah. Okay, so please wait a little bit. Okay, actually, there are many positioning papers as the position from American Academy. However, our paper is very updated in 2019. All these are my recommends. If you have time, it's very good papers. However, today we will talk about this paper from European Society. Okay, let's start with the fundamental. CBCT should be considered on a case-by-case basis where lower dose conventional radiograph does not provide adequate information. Like this tooth, patients have symptoms, but from the plain film, you can't find anything. So you move to CT. However, every time you start with the conventional film first, and after that move to CT. Like this case, even from the plain film, you can't see anything. But in CT, you see the crack line here and the bone loss around the tooth. And you select case by case, like a tailor-made for each patient. And as part of this justification process, only high resolution small field of view, which is diameter less than 5 centimeters, is applicable in endodontics, thus minimizing the effective dose as well as improving spatial resolution. So for endodontics apply, we choose only high resolution and small field of view. Let us talk about resolution first. The resolution of CT is dependent on the voxel size here, which is the smallest building block of 3D image, same as pixel that you know in 2D image. The smaller voxel size, the better spatial resolution. This rapid composed of different voxel size from the small to the large one. And the resolution is increasing with smaller voxel size. This one is smaller, so the resolution is better. And if you use the smaller resolution, smaller voxel, it means that you can see the image as same as the object. This one is from paper. They do a vertical crack line here to compare between the voxel at different size. The left one is 0.1 and the right is 0.4, which the 4 times bigger voxel size. What do you think here and here? Which one you can see the crack line better? Yes, the smaller voxel size here, you can see the clearly and sharp crack line here, right? But here you can't see, just like the not clearly seen. So as I tell you that the smaller voxel size, the higher the spatial resolution. For the KO or P3D, they have 4 options for resolution: the low dose technology, the standard, the high resolution, and the ENDO, which is the best one. And the voxel is 280 to 320 micron for the low dose, with quite big. But for the endo scan, it's about 18 micron here. However, whenever you use the resolution, that very good resolution, the dose is more if you compare with the low dose. If we compare the size of voxel between each option, I will compare the voxel size here. This one is the endo mode, and this one is a high resolution and standard resolution, and the low dose is the biggest voxel size. If you compare between the smallest voxel size for endo and the biggest, is the low dose technology. It's the 4 times bigger. So you know that if you choose the less voxel size, it's sharper, the resolution is better too. Let us compare between high resolution and standard resolution. Here, it's the like a half bigger. So you can choose the different mode for proper I will show you a little bit about the low dose and standard resolution. This one is trying to find the lingual canal here. For the standard resolution, you can see, but for the low dose, it can't, right? And this one is trying to find the canal, inferior canal, and the trabecula. This one is the low dose, and this one is standard resolution. You can see clearly canal on the standard, and for the trabecula, but you can't see on the low dose. So for endo mode, we use it because we need to find very small, like the lamina dura or the PDL space. So we will choose only high resolution and endo mode. The second part is the criteria for use of Cbct in endodontics. The example of indications include the following 8 topics. However, today we'll focus on only 3 topics. The first one is about detect periapical parodosis. When the signs and/or symptoms are non-specific and we can't find any clue in the plain film, we use Cbct. The earliest sign of periapical parodosis is discontinuity of the lamina dura. Here is the lamina dura, and another is the widening of PDL space, like here. So this one called periapical periodontitis, and it's the earliest sign. If you can find the earliest sign, so it's better for patient and better for prognosis. The average width of PDL space is less than 200 microns. And optimal resolution for CT that you want to detect the PDL space widening should less than 200 micron too. Back to mode of OPTD scan. The voxel less than 200 micron are endo, high, and standard resolution, or 3 mode. So we don't use lower dose scan here about the endo. And we will talk about the widening of the PDL space, that is the earliest sign of apical periodontitis. It defined as a periapical radiolucency that connects with the apical part of a root that exceeds at least twice the width of the PDL space. So normal PDL space less than 200 micron, right? So if you find that the PDL space wider than 2 times, so this is the earliest sign of periapical radiolucency. However, when you compare, you should compare between the same root or the same tooth, because each tooth have different wider of the PDL space. Okay, let us see a little case. What about tooth number 36? What do you think? Do the PDL space widening or not? Maybe you can see here, but not sure, right? I will show you the CT scan. How about CT scan? You can see very clear here and here, right? So because sometimes that you don't sure, sometimes CT help you a lot. And PDL space widening, like I said, that is the earliest sign of periapical radiolucency. I will compare about the CT scan here and the plain film. Another case about tooth 16 here. What do you think? Is it PDL space widening or not? Maybe you think this area is PDL space. However, it's quite hard because this is a sinus. For CTE, actually, even it's quite hard for CT too. You can see a little bit widening here, right? But for CT, we got more information here because the floor of maxillary sinus was perforated by the infected tooth here. And you can see the mucosal that thickening because of the inflammation. So we're quite sure that this root is the problem, is the cause of the problem. This paper compared the accuracy in diagnosis the apical periodontitis between periapical radiography, which I will call it as PR, and CBCT. The histology is gold standard, and this paper did in dog's teeth. Therefore, the sensitivity was 0.77 for PR or the plain film and 0.91 in CBCT. 0.91 is quite very high, right? Because 1 is the most highest. So it means that CBCT can detect periapical radiolucency about 91%. This paper compares PR and CT with the gold standard, which is the histology part. For histo, they detect by the cell, the inflammation cell here. If you found the inflammation cell here, it means that this one has inflamed and it's called periapical radiolucency. However, the gold standard don't detect about the bone. Even don't have the bone loss, they think that this one is the periapical radiolucency. So you come back to see the table. This one is periapical radiograph and this one is CBCT. This one shows the number of roots detected by PR, CT, and histo. The best one is histo, right? And the worst is the plain film. However, we will focus on the CT. You can see that CT can detect 7 canals that have the periapical radiolucency. But this paper said that they can't detect it because it's quite very small and the low bone loss. This table shows the false positive in PR and CT. It's 0. That is, whenever you detected apical radiolucency positive in PR and CT, it confirmed that there are lesions. But for false negative here, so, okay, the NPV or negative predictable value for PR diagnosis was 0.25. That means when an intact periradicular region was diagnosed by PR, 75 of the case actually had apical periodontitis. So it means that you think that this one is very good, you can't detect anything. However, 75% have earlier sign of apical periodontitis. So you will miss 25%. In conclusion of this paper, a CBC scan was more sensitive in detecting AP compared with PR, and plain film more likely to miss apical periodontitis. The second one is CBCT in the anatomical complex systems. For the example, as in finding MB2 canal. This recommended is the same as recommended by Cdentech CT, which recommended CBCT in multi-rooted teeth in case that the conventional radiograph not provide adequate information. I will show another paper about detecting accessory canal in mandibular first molar. They compare between 4 methods: CBCT, clinical inspection, digital radiography, and microscope. Here, they compare 4 methods to find the accessory canal. Let's see the result. First, with the plain film. Even you shift till, you can see that none of accessory canal can detect it. So the plain film is not okay for detecting the small canal. We don't use the plain film to find the accessory canal. How about clinical inspection? Yes, it detects more. You can see actually it detects the most. It's about 15 canals. But the problem is only 47% of detected canal can instrument it. So it means that you think that all that you do find is accessory canal, but not, it's just the half. So this method is not precise. What about the microscope? I think that you know that the microscope is very effective, but we will see the result. Yes, for the result, it's very effective too. We found the 13 canal, accessory canal, and it's very precise. About 85% can find the accessory canal. So this one is the most effective method. How about the CT scan here? It's the effective method too. We come back to see the result here. They found 12 canals. If you compare with the microscope, it can't find only one canal, less than the microscope. And it's quite good because you can see the morphology of the canal. So in conclusion, there was good agreement between microscope and CBCT, whereas DR and CI was not precise. So the third one that we will talk is for detect the periradicular bone chains, which indicative of root fractures. This is the shift tube of tooth 16. Can you detect anything here? It's quite hard, right? Maybe you think that this one is not normal, but the PDL space still can see. So we move to CT images. This one is a CT image. You can find that there is a very large radiolucency here, surrounded this root, and this one called the J shape. The J shape is like the indicative sign of the root fracture, because normal, if this tooth infected by the dental caries, the apical area will show the radiolucency, but the epicenter will cover here at the apical area, but this one is not. So maybe there's a crack at other or somewhere here. And we check it when we open the flap. If we compare between the plain film and CT image, is it different? For me, I think it's very different. In here, maybe you think, like I said, oh, is it normal or not? But this one is clearly see that this one is not normal. However, when you use CT, if you want to find crack, it's very hard. Why? Because you need to think and concern about the artifacts. The presence of artifacts in images is a factor decreasing CBCT image quality, especially when there is high radiopaque objects such as pores, metal restoration, cataplasma, and root end filling. I will show the images of same specimen which has and has not cataplasma here, or this one is the same specimen. This axis CT compare between this one with a no fracture here and with this one has incomplete fracture. You can see that you can detect the incomplete fracture here. And this one is the same root canal, which plays radiopaque cataplasma. The right shows many artifacts here, right? So can you tell me that is it cracked or not? Actually, this one don't have any crack, but the artifact has very same. It's a beam hardening, streak, and dark band. So it's quite hard that you tell that is it cracked or not. Even you have the crack here, we can't tell because about many artifacts. So I want you to concern that when you see the cataplasma marker or the cloud, so you need to concern about the artifact every time. We'll back to the fundamental of root fracture. This one is very good book. The periapical radiography will only detect root fracture if the root fragments are displaced like this, or the X-ray beam pass through the fracture line, which very hard. Even you can you try to shift tube like this. If it minimal displacement, you can't find anything. Actually, this case, it has a crack line here. However, we can't see anything, right? So I think that it's better that you know the radiographic features that suggestive vertical root fractures. The first one is the most simple. It's the separation of root. This one is the easiest, right? But normally, the root fracture may not separate the teeth, so we focus on the secondary chains of bone, which help us to indicate root fracture. These patients have a symptomatic at secondary mandibular molar from the shift till here. You can't see anything. But from CT with the same tooth, you can see the bone loss here and here, right? And we confirm with the clinical. So this is the secondary bone change that you can detect from CT. But from periapical radiograph, it's quite hard that you think that is it normal or not here. But CT, very clear. Another sign is widening of PDL space on one or more aspects of root or periradicular radiolucency in furcation areas here. Okay, we will look at case. The 40-year-old female has pain when chewing, and you can see very clear crack line here. Back to the plain film again here. What do you see? You can see the PDL space widening, right? However, for the CT image, you can see the crack line at the axial here. And even you can detect, you can see the PDL space widening here and the bone loss here. So only this plain film. I think that if you want to treat these patients, you will not sure what do you plan, right? But because we have CT scan here, and we're quite sure here because we can see the crack line here. So we extracted this tooth. When we try to find the crack tooth, actually, like I said before, that is quite hard that you find the crack line. But I want you to know about the secondary bone changes, like the PDL space widening or the bone loss here. Or this case that you can't find anything change, just the PDL space widening. But for CT, you can see the J-shaped radiolucency. In conclusion, the optimal resolution of CT imaging system used in ENDO should less than 200 micron because this is the average width of PDL space. And you should select a small field of view because it's reduced dose and your quality of image will be better because it's less scattered. And CT, you can use it to find the accessory canal like MB2, but please concern about the radiopaque material. The last one about the root fracture, if you want to find the crack line, I think it's very hard to find. However, you can see the periradicular bone change or secondary bone change. Okay, thank you very much. And I would like to thank you, my support team from KO and Udom Medical. ขอบคุณค่ะ
Thank you so much, Dr. Gigi. It's very, very nice and very, very clear for us to understand what CBCT can help in endodontics. So thank you again. And now please allow me to welcome Dr. Phong from Vietnam. Dr. Phong will introduce what CBCT can help us in our implant treatment and implant diagnosis. Hi, Dr. Phong.
Yes, hello.
Good to you.
I will
Thank
share
you.
my screen. Yes, okay. Yes, hello everyone. Thank you, Dr. T and Dr. Isti about your very interesting presentation. Thank you all of the colleagues still be here until now to listen my presentation. I'm very happy. I'm very glad because in a few minutes before, my standby or my senior in TMDU, Dr. Melissa from Indonesia, just say hello. Yeah, thank you, Dr. Melissa. And the topic I will talk about computer CBCT in implant planning. As we know, the dental implant are common procedure used to replace the absent teeth, very common now. And the radiology has a role in the pre-implant planning as well as the post-implant assessment, including identification of the complication. We will talk discuss about the accuracy of the combined CT just a little, and what we can consider relate to the field of view, the resolution, or the density of the bone, and the common lesion in the jaw, and also the anatomic process before we install the implant and the pre-implant diagnosis. As we know, for many research about the MSCT or MDCT, multi-slide or multi-detector CT for more than 20 years ago, they talk about the accuracy, and it's for recently, 2005, they said that the CT is accurate for the implant planning. And how about another research? They report the error in the measurement within 1 millimeter. Or another research from another hand, but not every case. Hanazawa in 2004 thought that the error in the distance from the alveolar crest to the mandibular canal were within 1 mm cadaver. Also in the direct CT, 93.7%, but in the multiplanar reconstruction CT is less than 90%. How about the accuracy of the cone-beam CT? So because the cone-beam CT, they have a strong beam hardening. So we worry about the accuracy, but many research show that the cone-beam CT is still they have the accuracy equal, or some research they have more accuracy or less accuracy than the MSCT. But almost the research so that the cone-beam CT is accurate as the MSCT. It means we can use the cone-beam CT for implant planning. However, in the cone-beam CT, because the patient take the scan time is about 14 seconds. So when they stand up, is maybe take time. So the patient can move, and that time they have the motion artifact. So when we measure the bone about the length, we be careful with the cortical bone around here. On the other hand, with the cone-beam CT, the soft tissue in the soft tissue area with the fast tissue or the connecting tissue or muscle tissue, we cannot see clearly like the soft tissue bone in the window of the MSCT. So in that time, we not easy for us to detect the pathology in the soft tissue area. For the cone-beam CT planning the implant, we also consider about the field of view. Depend on the reason of the risk about image quality, radiation dose. We will choose the small FOV less than 5 cm, like in case it's a single side of the implant or just the post implant assessment. For the home, like normally we can use the medium field of view with a scan height from 5 to 15 cm. It's the popular FOV in the medium size for the both side of the jaw. Another with the large field of view. In this case, it means more than the height more than 15 cm refer in the Jim-Goma implant. About the resolution, the Vorsell, Dr. Easy already talked very clearly, and we just saw some similar about the spatial resolution. Is depend on the quality of the flat panel detector, the X-ray source, or the reconstruction of the machines, and the range from normally range from 0.076 mm to 0.5 mm. But normally we use it is optimal for the diagnosis with the implant from 0.125 to 0.3 mm for the diagnosing the implants. We need to consider about the resolution and the dose. If we increase the resolution, it can increase the dose. However, for the surgical stand, if you want to make the stand or 3D print stand or CAD/CAM stand with the combined CT, the Vorsell size is better, less than 0.2 mm. And that time we will export the DICOM file. With the bond density, follow the Casmith, he divide the bond density in 5 times from D1 to D5. D1 very is more than 1,250 household units, but D5 is less than 150. They measure with the multi-detector CT. How about with the combined CT? Although the household university units is available as many software on many combined CT machine. So, but the combined CT household units value very significant from machine to machine, and also different with the MDCT value. So in that case, until now, recently, the household units value are skewed. For that reason, we be careful to measure the density of the bond with the combined CT. Another very helpful of the combined CT, when we install, make the plan for the implant is about the multiple planar. I like this because when we before the diagnosis, when we make many planar around the teeth, we can discover any pathology or any dangerous structure. For this case, like this, they show the sagittal combined CT in the lateral canal. It's not easy when you see with the 2D planar. If you can see the lesion lesions in the center of the dental of the teeth, it affects to the lamina dura as well in the bone. So in case if you install the implant in this area, you need to solve the inflammatory around it first. Another, in this case, the radicular cyst related to the endodontically retreated in the axial combined CT and the sagittal combined image. They show the labial expansion with effect to the cortex bone. The lesion is centered at the mid-root region, mesial labeling, suggesting that cyst is likely to be related to a root fracture on the lateral canal. For pre-implant diagnosis, we sometimes the patient come to our clinic, they have the lesion like this, so a radiobasity lesion with the radiating brush line border on the panoramic radiograph. On the axial Cbct, so very well defined homogeneous opacity density, slightly lower than the cortical bone, but still have the brush line border. So they think this is the bone we notice this is the bones islands. So don't need to do any treatment, just follow up in this case. So in this case as well, we have on the panoramis, so very well defined homogeneous opacity isolate with the cortical bone and the buccal cortical with no expansions around here, with no expansions. The opacity is stand around the mandibular canal with neither deflection nor compression. This decay also the bone islands. So in the clinical case, we will usually miss the bone island like this. In this case, we just follow up and make the plan avoid the bone islands. This is another case with the bone island in the left mandibular areas. So for the implant planning, we also can see in the periograph with the retained root. We can make the plan with the three-step software with the three-party software. We can measure in the three plan and make the surgical guide and make the implant easily. This is not the case. Depending on the case, they can instruction the root or they avoid the roots, depend on the surgery. So with the convenient CT, we can make the plan with the three planner. It's another case with the peri-implant diagnosis. So in the periograph, we look this case like it's normal, the bone. So if beyond this, we can install the implant in this area, but in the convenient CT, we can see the inflammatory in the lungs. So before install the implant, we need to solve this the problem. In another case, so in the right anterior mandible, with the axial and sagittal convenient CT, we can see the well-defined non-expansionally in the corticated lucent lesion, with slightly thinning on the labial cortex, which remain reserved. We can see it is still reservation of the incisor lamina dura. So in this case, we diagnose it is the same bone cyst. So some case we have the radial lesion, but it's not the radicular cyst. It's not inflammatory. Beside the pre-implant with the inflammatory lesion or some pathology problem, we need to consider about the hazardous anatomic structure. Like in this case, before we sinus, some case we have the sinus augmentation before the placement of the dental implant. We need to consider about the sinus floor. We have some to avoid the severe bleeding may occur with the arterial injury. We need about the blood supply in these walls. This slide shows the alveolar canals in the anterior wall of the sinus. With the small FOV, if we choose the good resolution, we can see clearly with the anterior. In this study, so the alveolar canal were identified in 55% of the maxillary sinus at the first molar region. The mean distance from the alveolar ridge is the shortest, with a distance around the mean around 16.9 mm. In this slide, show the comparison of the bone density between the molar part and the maxillary tuberosity. In the maxillary tuberosity, so relatively lower the basal value than the molar parts. To stabilize the implant in the maxillary, implant are often placed in the thyroid process. Also in this slide, the resto-palatine foramen exits from the proximity to maxillary tuber. It's important to be careful about descending palatine artery and the preter-palatine nerve in the preter-palatine canal. In this slide of the cone-beam CT image show of the preter-palatine foramen is quite large. We also consider about the incisor foramen located in the palatal side of the maxillary center incisors. The left side is the dentatus maxillar and the right is the edentulous maxillars. And this slide shows the difference of the alveolar shaft between the dentatus and edentulous. The loss of the central incisor induce the shorten of the distance between alveolar crest and the incisive foramen, and the incline of the alveolar crest is also changed. Is also changed from when we lost the teeth. In this study, they saw the incline of alveolar bone in the dentatus were about 5 degrees smaller than that in the edentulous, and the distance between the alveolar crest and the foramen in dentatus were 3 mm longer than the edentulous. For optimum the implant placement, after loss the incisors, the dentist must take into consideration of the morphological change of the incisor related to the alveolar bone. And this slide shows the cone-beam CT image of the cadaver image of the mandibular canal in the patient still have the remainder teeth. But in the edentulous patient, the cone-beam CT shows that the foramen is present on the alveolar crest. The distance between the mandibular canal and alveolar crest in edentulous is shorter than that in the patient still have remainder teeth. Another anatomy we consider about the mental foramen, about the anterior loop. You can see the mental foramen around here, but some patients they have the anterior loop forward. In this study, they have the incidence of 71%. The people have the anterior loop. The length of the loop means 2.7 mm, and the longest anterior length is about 9. They have one case 9 mid-mm. The measure from the anterior margin of the mental foramen is the most popular. So they can, the accessory mental foramen, they can, in this case, they can lower or upper or behind, or they in the measure. The occurrence of multiple mental foramen were reported when around from 6.7% to 12.5%, and the rate of accessory mental foramen present were 0% in the patient when we use the cone-beam CT. With the accessory mental foramen, it can be in the superior, inferior, or mesial, or in the distal areas. In this study, so the most accessory mental foramens were located in the distal and in the inferior of the mental foramens. In the next structure, we want to consider is the lingual foramens in the midline, in the middle line. In the lingual foramen, we concerned about the sublingual artery. In this research, we can see around the mental spine. The artery can be upper, lower, or be left or right. With the sublingual artery were identified with the upper, lower in Japan, but in Vietnam, we have a research only how the sublingual upper or lower on the middle. We don't have on the left, on the right. We have 51%. They have upper and 48% in lower, and only 1% in the middle of the mental spine in Vietnam. For the lingual foramens, the frequency, we have some the lateral lingual foramens in these areas are around 60 to 70%. They have the submental artery were found in the lingual foramens. Before the install the implant, we also be careful about the morphological shape of the mandible. In this area, they have the submandibular fossas. So in case we make the surgical stand, or we have only have the 2D plan radiograph, be careful because they have the concave shape. So no, only this is the submandibular glands located. So for the cone beam CT in implant planning, we can see it accuracy modality for planning. It's helpful because with the multi-planar, we can see when we make the plan, we can see around the implant. We can see the pathology area as well as the hazard anatomy structures. Also, we be careful about the hazards and structure I already mentioned in the maxillary and also the mandibular areas. We consider about the FOV, also the resolution. If we increase the resolution, it also increase the dose. And until now, the density of the cone beam CT, it cannot compare with the MDCT or MSCT. Yes, thank you very much for your kind attention.
Thank you so much, Dr. Fong. It is very, very nice to see all these nice pictures with your explanation. So we will move on to the Q&A session now. Let me open up this. Okay, let's see. So we have a question for Dr. Pemporn. What slides do you recommend for evaluate the length of root canal? Is it axial, coronal, or sagittal view? Which one is giving us the best information for our CT? Thank you. Dr. Gigi, you're on mute.
Okay, I will show this slide.
Okay.
Okay, actually, when you want to measure the root canal length, first you need to find that which section is. Please wait for the slide a little bit. Okay, like this slide. Okay, you need to try to rotate the slide until you find that canal, all the way part of that canal. And if you can see clearly, so that is the slide section. Like this case, I'm so sorry, I can't rotate. However, this one, you can see the canal, right? So another thing, you need to find that what is the reference point. So if you use like the mesial cast or distal cast, distal buccal cast, you measure from that reference point to the root apex. And you measure maybe not just one section. This is the parasagittal plane, and this is the paracoronal plane. You try to move, to rotate until you see clearly part of that canal like this, and you measure. So you get the root length that quite accurate. Okay, Ka, thank you for your questions.
Thank you so much, Dr. Gigi. So we have another question. I think this one is addressed to Dr. Itzi. Is the segmentation of root canal anatomy possible, and which software would you recommend for segmentation?
Okay, thank you very much, Tiffany. About the software segmentation that we use in our lab, we have the software from Materialize that is Mimics, usually that we use to segmentate the anatomy of the bone, and also one that used in the orthognathic surgery, the one she used the Amira software. And about the first question is about the root canal. Yeah, I think the basic segmentation of the root canal is almost the same like basic segmentation in the pharyngeal space. So if you want to segment it, because one of my friend now, she studied about the segmentation in the maxillary sinus. So everything in the it's depend on what kind of the point that we use, that we want to segment it. So any kind of the anatomical structure in the bone in the body can be segmented with the software.
Thank you so much. So since this question is regarding the root canal, Dr. Gigi, do you have any recommendation on the root canal segmentation?
I think that normally we use the MTR, multiplane reconstruction, because you can move all along. And like I said, that because the canal is not a straight, right? So sometimes it's like a curve. So you can move and change until you see clearly of that canal.
Thank you so much, Dr. Gigi. So we have another question here. It says, what is the most ideal choice of the resolution for CBCT that, because high resolution, it actually has high radiation, right? So what is the recommended resolution? But it doesn't say anything about what is the treatment. So I guess this question is to Dr. Fong. So the question is, are there any side effects on the surrounding tissue or landmarks if they select high resolution?
Yes. When we make the surgical stent, if we use a high resolution, it's much better with a low resolution. Especially when I use the triceps or the three-party software, it's make clearly identify and the landmark and also the bone for me to measuring. Yeah.
Thank you, Dr. Fong. Dr. Itzi, do you have any recommendation here, since it's a bit related also to the radiation safety, that higher resolution that they select, the higher dose it will go to? So is there any recommendation for the audience that how do they select the proper resolution?
Okay, the resolution itself, it's depend on what a specific task that we want to use. It's like for endo, like we want to have like a high resolution. So we need to choose the high resolution one. But I think for like many cases, like maybe for the dental impacted teeth or like maybe implant planning. We don't need to have like a high resolution, but it's like the first principle. It's like ALARA, as low as reasonable achievable. It's always for the dental radiologist to choose which kind of the resolution that we want to use.
Thank you, Dr. Yizi. So I think today we also hear from Dr. Feng, Dr. Gigi, and Dr. Yizi about different treatments. So the purpose of us having 3 speakers to talk about different treatment is also to highlight the importance of selecting different FOV, different resolution to fit to your treatment. So there is no right answer in CBCT what resolution to go for or what FOV to go for. So hopefully in today's session, we share all these case and the treatments and the diagnosis for everyone to know what will be the best option for you when it comes to your own treatment plans. Okay, so I think we have one more question here. So this is regarding the CAD/CAM and 3D printer. So I guess this is for Dr. Feng. The question is, how do we use the DICOM file from CBCT into 3D printer? So I guess this is more of the CAD/CAM side, like after we do CBCT, how do we use this CBCT DICOM file together with other 3D printer machines?
Yes, actually, from the Convin City, we export the DICOM file to another software, like Precept or Nobel Clinician. So from STL, that file, after we make the plan, we export again to the 3D printer with the STL file for print. So we don't export the STL from the Convin City, only the DICOM data, and that's enough for we make the plan.
Thank you, Dr. Feng. Yeah, so what Dr. Feng was sharing just now also with the surgical guide design, the CBCT is providing only the DICOM. And what you need is another called STL file together for the design and print out. So let's take a look if we have other questions.
Yes, there's a question in the chat, Tiffany.
Yes, I will need Liz to help me.
Okay, okay. There's a chat in English actually from Dr. Erwin. Thanks for all the speakers that have a great presentation. I would like to ask Dr. Fong for make a simulation in implant plan with CBCT. If we didn't know the type of the implant that will be used for oral surgeon, so what kind of the default type of implant that we use to make the simulation? So yeah.
Yes, they have like a lot of type implant with the third-party software. You can choose any in the market, any. Yeah, they update every year, so you can choose different type of the implant for the simulation. Yes, they can choose the size, the type of the implant, and the length or the diameter, everything. Yeah.
Thank you, Dr. Fong. And maybe Dr. Isti, you want to add the answer because you ever did the webinar together with Dr. Marek regarding this, right? So I believe you have additional explanation, Dr. Isti? You're still mute.
Yeah. Yeah, it's from my experience that when we do simulation for implant, it's depend for the anatomical structure of the that we measure. that if we measure some specific, like with the height, or 10 with the weight of 5, then we just directly go to the list of the implant and then choose what kind of implant that use. It's just like simulation. If we do with the specific, like usually, maybe we can talk with our colleagues that usually what they use of this implant, the brand of the implant, and then we can choose the one, and then just adapt and with the anatomical structure of the measurement.
Dr. Gigi, you also did some lecture for implant previously, right? Do you have any?
Because we are an oral radiologist, usually we combine with another clinician from ENDO, from maxillofacial surgery, and then we make collaboration on it.
Implant, right? Okay, I think that the first one, you need to survey that area, the bone height, bone width, and morphology. And after that, you can, like, we have the rule, for example, that if you have the canal, we need to have the safety zone 2 millimeters away from the canal. So you choose the implant and the size from the bone height and bone width. And after that, the program will help you because you can select the same size. It's called the virtual implant. So you choose that virtual implant that you will do in patient and try to place it first in the CT.
Thank you, Dr. Gigi. So I think for implant, we all can have a lot of explanation and sharing over here. So because of the time, let's do one.
Sorry, Tiffany.
Yes.
Okay, is there one more question? Is that possible?
Yes.
Yeah, sorry. This is for all the speakers that some of the doctors here, they find the difficulties to take a good panoramic X-ray. They said that the panoramic X-ray most of the time the lower incisors look shorter than what it should. Well, is there any tips or trick or how to get it better? Thank you.
Okay, maybe I would like to answer that question. It's like for my slide, it's depend on the position. I think at the first, if we want to have a good related with the quality assurance of the radiograph that produced in the installation, is like the position of the patients itself. If the patient have a good position, it's like when I said before, if the patient is get too downward, and then it make the shorter of the length of the teeth in the lower jaw. So I think it's mostly we have to make sure that the patient have to straight between the cervical spine, between the back of our head, and also all of the patient, and the FHP of the patients is always have to align. So I think if we have make sure the patients have on ideal position, it won't be there's error on this lower jaw.
Thank you, Dr. Iti. So actually for today's session, the very beginning, we invite Dr. Iti to talk about the image quality. Actually, this is like something everyone was aware that OPG panoramic is sometimes very tricky on the positioning, on the result. And I think that is also a very important point. That's why we put it in the very beginning of today's session. And hopefully followed by Dr. Gigi and Dr. Fong, all the sessions that we're providing today helps you with your practice. And like in our title of this webinar, we want to help you to bring CBCT into your clinic and in your daily practices. And for CBCT and all these dental imaging to actually help you instead of like causing you problem or headaches. So thank you everyone again for joining our webinar. And later on, we will have a very quick feedback form for everyone. So I will put it in the chat. So if you have time, please help us to share what do you feel about this webinar, and I will put it in this group chat for you to just click and then access. Yes, thanks, Liz. I will also put this chat over here. Okay. Okay, so once again, I would like to thank Dr. Izzy, Dr. Gigi, and Dr. Feng today for your time and spending sharing all the very, very valuable content and your experience with us. And I hope everyone joining us today have a nice evening, and then you can access this link over here with the QR code or the link in the group chat. So once again, I hope to see you next time. Thank you.
Okay, thank you so much. Once again, thank you so much for all the speakers, Dr. Isti, Dr. Gigi, Dr. Fong, and also our wonderful moderator, Tiffany Wang. Thank you so much.
Okay, thank you so much.
And this is the post-test link for Indonesia Doctor. Please kindly scan the QR code or click the link in the chat. I may need some help from the Indonesian teams to copy the post-test link in the chat. And we also send the post-test link to our follow-up email. And okay, and just like what Tiffany already said and asked, this is for all the participants. Please kindly help to spend about 2 minutes to give your feedback, because your feedback is extremely important for us as well. Okay, you can scan, and also there's a link in the chat that Tim already copied. Okay. And now we reach the end of this session. Once again, on behalf of Envista team and PT Andini Sarana, thank you so much for your kind attention and participation. We sincerely apologize if there's any inconvenient experience during the webinar. And please kindly follow our social media accounts, Senyum Bersama Indonesia and Andini Sarana Official, and our extended partner account Belanja Gigi for more information about our next education program. Once again, thank you so much. Stay healthy, stay safe, and see you again. Bye.
Bye-bye.
Thank you.
Thank you very much. See you again.
Bye. Have a great day. Have a great evening.
Bye-bye.
Bye-bye. Thank you.
Thank you very much,
Thank you.
Mr. Elizabeth, Miss Elizabeth.
Thank you, Dr. Gaga. Oke, thank you so much. Terima kasih PDGI Jakarta Timur atas supportnya. Terima kasih Dr. Gaga. Kami juga turut berduka cita Dr. Gaga baru dapat kabar dari Dr. Fedi, keluarga dokter, dan dokter baru berkabung tapi masih sempat memberikan sambutan. Terima kasih Dr. Fedi. Terima kasih teman-teman. Terima kasih Dr. Joyce. Baik. Saya izin untuk, ya, thank you dok. Saya izin untuk end the session ya dok. Terima kasih. Thank you so much all.